Me when
All right, we're live. People are joining the room now.
Awesome, fantastic. All right, as everybody comes in, I want to welcome everybody to our JH Wiki Toolkit series. Giving a moment for everybody to populate and Marina said, tell me when I can actually launch. Let me know when most people are in the room, Marina's.
Yes, just a few more seconds. People are still logging in. All right, you can get started.
Awesome.
When you're ready.
Awesome. Good afternoon, everyone. My name is Allison Agu. I'm a professor of adult and pediatric infectious diseases. And in this role, I am the program director of the Ryan White Part D, Johns Hopkins Wiki, or Women, Infant, Children, and Youth Partnership for Excellence in HIV Care across Central Maryland. And our toolkit series, if you've had an opportunity to attend before, the effort and the goal is to engage and amplify all of our voices to better, good, and optimized care. So briefly about us. The JH Wiki, we represent 6 distinguished programs, and again, dedicated to providing quality and comprehensive family-centered care and social support to women, infant, children, and youth Wiki across Central Maryland. I represent the Johns Hopkins Pediatric Adolescent HIV/AIDS program. We have Jean Keller and Anna Powell, who are the co-directors of the women's program. We have Sarah Rail and her group at Sinai Hospital, University of Maryland, with Matt Grant and Vicki Tepper, which represents University of Maryland. Aminata Sanders and Errol Fields at Johns Hopkins Emerge, or Gender Affirming Care Clinic, and then Glenn Treisman in the Johns Hopkins Psychiatric Service. Our vision overall is to really achieve a more coordinated response to HIV care by establishing mutually beneficial relationships. And the idea is that we work together, sharing, caring to increase the quality of care for that we provide the Wiki populations as a community, and to build upon these structures and systems to provide a dedicated network to provide care to these populations. And the goal of this series in particular is to engage and amplify the voices of local experts. So we'll hear us see something, say something, share something. We want to hear from you as well. We are lucky enough to be funded by a HRSA grant, and the number is there. So here are upcoming toolkits. I want to tell you what's coming. We know what's happening today, but to give you a sense of what will be coming in the future months in terms of trauma-informed care, marijuana, and HIV connection in 2023, and then June of 2023, optimizing care for seniors living with HIV. But right now I'm going to turn to the conversation at hand, which is crucial conversations interrupting perinatal HIV transmission. They're not going to speak just yet. We'll do a little bit of a background, but on the call and on the webinar with me today are David Griffith, who's an assistant professor in Division of ID at Johns Hopkins in School of Medicine. He's both Med-Peds ID trained and cares for youth across the spectrum, and is the medical director of the Johns Hopkins County HIV program. Matt Grant, assistant professor at the University of Maryland, medical director of their Adolescent and Young Adult Center, and including the SPICE program, which provides primary care and HIV surveillance to HIV-exposed infants. We have Anna Powell, who's an OB and assistant professor at Johns Hopkins, and co-directs the JH Women's HIV program, and for women who are living with individuals living with HIV who are pregnant. Jean Keller, assistant professor of gynecology and OB at Johns Hopkins, and co-director of the HIV Women's Health Program. And she's the most senior of us who has been providing comprehensive gynecologic care since 1993, but she and Anna provide preconception counseling all the way to full care across the spectrum. And then last but definitely not least, we are honored to have the presence of one of the moms of the recently diagnosed children, because I think her expertise is clear as a mom of these patients. So with that, we'll dive in. These are my disclosures and everybody's disclosures. And the objectives today are several-fold. One is to discuss the trends in perinatal HIV transmission in the United States, but also here in Maryland, to review the guidelines and recommendations for preventing transmissions, and then importantly, to examine the cases of recent transmissions to identify key issues, barriers, stakeholders, and opportunities to interrupt future transmissions, and again, to share and discuss and to amplify. So Just to make sure we're speaking with the same definitions, perinatal transmissions means the transmission of HIV from an individual living with HIV either through pregnancy, labor and delivery, or in breastfeeding. And we'll talk about in the subsequent slides, we have several things and tools in our armamentarium to preventing maternal child transmission, or PMTCT. And what are those tools? So the current protocols for PMTCT in the United States include universal testing, and that's for all individuals between the ages of 13 and 64. Knowing your HIV status is a vital sign. We should all know that status, and their recommendations for testing across the board. And then within pregnancy, maternal testing in the first and third trimester, and definitely at delivery if unknown. And then maternal ART, and that includes IV or intrapartum AZT prophylaxis. And not all centers do that. It's a plus minus in the guidelines, depending on the viral load delivery. And then this infant AZT or azidovidine, plus or minus nevirapine and 3TC in a risk-dependent fashion that is given for 4 to 6 weeks of infant prophylaxis. And then there's infant testing and making sure we know what the infant status following delivery. That does not exist on its own. It has to exist within a framework to eliminate perinatal transmission that includes collecting the data, include case review when there's something that happens or a change, includes facilitating psychosocial as well as clinical services. All the things have to come together for us to get to where we have comprehensive real-time case finding and also interruption, which is what we're doing today. When all those things work beautifully, we know without any ARE or antiretroviral treatment, transmission from parent to child is about 25%. Where we are today with the optimal treatments, transmission should really be less than 1% and essentially zero if that is maternal ART, viral suppression during pregnancy, all the measures that need to be done during for prophylaxis for the child. Our rate should be less than 1% or less than close to zero. This is where we have, this is data from 2017, but this is showing areas of the United States where we have females ages 15 to 44 are typically considered the childbearing ages, though we know you can have pregnancies above and below that, and the areas where we have highest numbers of those individuals who are living with HIV, which just shows you the areas where we need to be thinking about where there may be more risk for transmissions of perinatal transmissions. And it does somewhat overlap, and these are the areas when you look at, this happens to be 2016, areas where children who are born with HIV where they live. So overlapping with areas, many places where there is high levels of childbearing age individuals. But this is an area where we do have some success, right? So perinatal HIV diagnoses have decreased from 41% between 2015 to 2019, from 143 to 84. It is not zero, and this is across the United States. And when we look at the perinatal prevention cascade, we must think about, again, several layers of what's happening. So there is the persons with HIV capable of childbearing, becoming pregnant, and what that number is, whether there's inadequate prenatal care, whether it's no or late HIV testing, whether ARV prophylaxis happens, and all those steps can lead to a child acquiring HIV. So there's data that coincides with that, and knowing how many individuals are eligible, how many individuals are in that childbearing age, what are the percent of persons who actually get prenatal care, what proportion of those are getting the appropriate testing, and again, what's the transmission rate at the end of the day. So there's data that has to be matched with those areas. These slides are modified to take away the stigmatizing language that were in them. And as we move to people first language, that's why you see me sort of overlapping those boxes, but making sure we're having conclusive or comprehensive language, inclusive language. When we look at who acquires HIV, and this is data from the CDC showing the timing of maternal testing and the children who are then born with prenatally acquired HIV. When you look at those infants that were exposed but not infected or did not acquire HIV, those parents, those moms were tested definitely before pregnancy or during pregnancy. So they were less likely to transmit because you knew their diagnosis and you could actually institute the measures to prevent. When we looked at the infants, and this is again between 2010 and 2016, when we looked at the infants that did acquire infection, we see a significant proportion of those moms did not get tested until after birth, or their status was unknown or at birth. So delayed diagnosis is truly a factor. But you do see some where there's before pregnancy or during pregnancy where they were tested and known. And this highlights where challenges with adherence, challenges getting medications, and part of what we need to be talking about, how to optimize those interventions. So when we look at the diagnoses of who those kids are, certainly you see much of the diagnoses happen in the under 2 years of age, with a big bump in the 0 to 5 months of age up to 23. But as you see, there are kids who are perennially acquired that are diagnosed way out, and happens to be those less than 13 who are diagnosed at later stages when they're concerns whether there is immunodeficiency or something happening, recurrent infections, and they're tested and diagnosed. And so it's important to be thinking about our differentials, even if we don't have a positive later on. Think early on, thinking about whether HIV could be at play. And we've had kids as old as 17 who are perennially acquired and were not diagnosed till their late teenage years. This is data from the Maryland Vital Statistics Annual Report, showing the number of individuals, the number of live births across Maryland, and that's between 2012 and 2021. And then the people of childbearing age living with HIV, living with diagnosed HIV, and showing they're cumulatively about 57,000. And then the reported perinatal HIV exposures, and that significant numbers of individuals are born and exposed with HIV, but very few diagnoses, as you see in the last slide. This is between 2012 and 2022, showing essentially that we have 0 to 3 at the max in prior years. And 2022, we have had in the last year, about 6 patients who are diagnosed with perennially acquired HIV. And that's why we're here today, because we're looking at that as not just a blip, but a major blip compared to the last several years of that decade. With that, I'd like to turn to Matt Grant to present the first case, and then we'll go in from there.
Thank you so much. So the first case that we have to present is a mother who presented to labor and delivery after a fall at 27 weeks. So it was sort of an incidental presentation. She had not been in prenatal care prior to this due to actually moving into the area and not establishing care. So she had been out of care for a fairly significant amount of time, and it's unclear whether or not she had been in any type of care in her previous location. So she had moved from out of the Baltimore EMA into our area. After presenting to labor and delivery from this fall, she did complete 5 prenatal visits. However, these visits were somewhat delayed by different aspects of different issues, including insurance access and transportation. She had somewhat of a labile viral load after that, ranging anywhere between 65,000 and 300,000 on presentation due to medication access, health literacy, a lot of other factors, just ability to actually take the medication and understanding her medication. And so at delivery, she actually did maintain a viral load of about 200,000. And she had an infant born to her by a C-section at 38 weeks with an initial viral or DNA, HIV DNA that did show a detected status. The infant had already immediately been started on a triple therapy based off of the HIV protocols. And the subsequent 3 tests did return as not detected. Following some consultations across the different providers across the country, we ended up withdrawing medications at 3 weeks, and immediately the HIV DNA returned as detected with a viral load of 160,000. With good weekly follow-up, this infant did have a subsequent decrease in viral load and has gotten down to about 32 on most recent checks. But I think this case really shows a lot of barriers and challenges, including insurance and housing, transportation, access to childcare for other children in the house, and general health literacy around both her HIV and prenatal care.
Thanks, Matt. Any questions for Matt before we move to the second case?
I have a quick question. So in terms of the insurance, this was in Maryland, correct? This is one of our cases.
This is
So
in Maryland.
so I don't know her specific circumstances, but all pregnant women can get are insured, not to mention the fact that we have funding to cover this if they're not sure. So I just wanted to throw that out there, that for those who might not know about what our state has available, that should never be a barrier, and we need to do a better job of getting that out.
You're exactly right. I think as we examined this case with this patient afterwards and recognized this barrier, this was a huge red flag for us internally when sort of examining her case individually to sort of shore up our support systems. And also to ensure that there's understanding both at the patient level. I think that's something that maybe we need to talk more about, is that every pregnant mom has access to immediately sign up for healthcare. It's a qualifying event, right? And I don't think that that's well understood. So then there shouldn't be a barrier to starting health to prenatal care immediately in any clinic.
Definitely. And I didn't say this before, but please go ahead and drop questions in the chat so we can circle back to them subsequently. I just want to make sure everybody's questions are there.
It sounds like there was a question, sorry, I see one that there was a question about mom's CD4 count. This mom was well known to us, actually. She had previously lived in our area, and her CD4 count was actually well below 200. So it seems like she had had a history of noncompliance and had moved out of our area, not well controlled, and had moved back into the area. She had actually been, she had a prior child that was taken care of by us in our HIV surveillance clinic, in our SPICE clinic.
Yeah. So it sounds like she's, again, known positive, but somehow, as people do, fall in and out of care, and was then not, able to initiate therapy earlier. And then Debbie Prasad is asking, what medications did the infant receive? Maybe prophylaxis and then for treatment, maybe Matt, to be specific.
Yeah, so under the prophylaxis medications, we use the standard of care. So we use zidovudine and lamivudine and nevirapine for 3 weeks, and we use them at treatment level doses. So we treated this infant as presumed HIV, and then based off of the HIV DNA and as a high-risk infant. And then after the viral load came back as at 160,000, we transitioned the baby immediately to abacavir, lamivudine, and raltegravir. And we did that as, we actually opted for that because of the standardized dosing that we could do to increase adherence options for mom. We felt like having everything be twice a day, and because abacavir and lamivudine, we could make the same dose, the same volume, it would increase opportunities for mom to be able to maintain adherence. And it worked really well for her. She never missed a dose. We were able to check medications every week with her. And the baby, like, his viral load dropped really great. It was a great choice for her overall.
There's a question about when this happened. I just say across the board, all of these cases are from 2022. These are not old cases. It's from 2022. Why don't we go on to your second case?
That's great. So this second case is a mom who presented a little bit earlier at 23 weeks. And she had been, she did not realize that she was pregnant at the time. And so that delayed her presentation. She presented to a outside OB, and then very quickly after presenting and getting her, at this point, she had gotten her prenatal labs drawn at 23 weeks and seems like it was a re-diagnosis. So she had previously been tested for HIV several years ago, but the linkage sort of fell through. There were some social factors that have been identified that prevented a successful linkage to a definitive treatment. And so on this presentation at 23 weeks, she was sort of re-diagnosed with HIV and by a 4th generation testing, which was appropriately done on the first prenatal visit. But very quickly after her initial visit, she went into PPROM at 25 weeks, was admitted, and they were unable to sustain or prevent progression. And she was delivered at 25 weeks as well. So very quickly after going into PPROM. Her viral load did come back at 550 with a CD4 count of 261. So, in the interim period of several years, she had sort of had a sustained level of viral load, and her CD4 count did depress. When the baby was born via C-section at 25 weeks, they were placed on IV zidovudine due to limited options at that time. And because all that the outside hospital had was that lower viral load to go off of. The HIV DNA at birth was actually initially QNS and then was reported as detected. There was a lapse in communication with our team, unfortunately, which resulted in us being unable to have a really quick response when this came back very quickly on a redraw as detected. Oddly, there was a repeat of a viral load which has come back as just 20, which is weirdly low, honestly, for us. It's not below 20. It's not detected on the panel, but it's just simply 20. They reported very low. So this baby did get increased to triple therapy with some help from some colleagues at Hopkins, and we were able to identify a good treatment dose for this small child. We've repeated the HIV DNA every 2 weeks. And each of them has come back not detected while on medications. And similarly, we've decided to withdraw therapy at 6 weeks based off of some shared medical decision-making between us and the primary team. And the initial HIV DNA on this has come back as not detected as well, with a repeat that's due very soon to continue the evaluation overall. Again, in this one, the biggest barrier seems to be some linkage to care and the understanding of HIV during that initial diagnosis. There was some social issues that were going on during that initial diagnosis as I've looked back at the case. But I think, this was appropriately treated when she came in at 23 weeks. A really unfortunate series of events leading her to early labor. We'll have to go from there.
I mean, the concept of re-diagnosis is one that I think we've seen, definitely we can all say we've seen before. It's almost as if people are diagnosed and for whatever reason, it doesn't register, it doesn't compute, and then they fall out of care. And then it's almost that they're surprised. And I think some of it is maybe potentially the stigma or the ability to even accept that that's a thing. And so, as we think about where to plug up the holes, it's how to make sure, as a system, recognizing how stretched our public health system is, that not to say that this wasn't done, but how do you make sure people continue to maintain in the fray, right? That they're continuing to maintain. Any questions for Matt before? Oh, sorry, Matt, go ahead.
No, I was just saying, I agree. Yeah, I think that's a good synopsis of it.
Yeah. Any other questions for Matt before we turn to David? All right, David, going to turn to you, and I know you're in the clinic in conversation with our expert mom that's there, so we're gonna. And David will stay off camera. So we'll turn to you all.
All right. Thank you, Allison. So I want to introduce our mom, and just first off, thank you for joining us. I know sitting through the early part of the talks, it's brought up a lot of emotions and feelings, and I welcome you to talk about those emotions and feelings, but also feel free to kind of keep that to yourself and not talk about it if that's what you prefer. So I want to start off and talk a little bit about your son, who was newly diagnosed with HIV this year at age 7. And first off, how is he doing?
He's good. He's a lot better now that he's taking medicines. And I feel like it's improved because at first he was really sick and I just couldn't figure out why he was always sick. And then when I found out, I was just heartbroken. I just didn't know what to do. And yeah, I didn't know. I broke down in the hospital and was just crying, like, what am I going to do? And the last thing I could think about was going to the doctors, because I just felt like it was the world's biggest fear, like coming to life. I already was worrying about myself, and now I had to worry about my baby. But now that we're in the doctors and he takes his medicine, it's gotten better. It was sketchy at first because he didn't like to take the medicine. He didn't know what it was to take a pill. So it was hard. But now he's good. He takes it with water or juice, whereas at first we were taking it with applesauce, and it helps. It's gotten better, but it was really hard at first.
Yeah, I give both you and your son a lot of credit. Right after the diagnosis, you guys came to our pediatric clinic here. For the kind of the audience, his viral load was, I believe, 700,000, and his CD4 count was 3. He had come to the emergency room. You would take him to the emergency room that day because he had a lot of mouth pain and mouth sores, which turned out to be thrush. And that's what led the emergency room to test him. And that's how he ultimately got diagnosed. And he's been taking the 1 pill once a day. It's called Biktarvy, the kind of pediatric version of that. And yeah, it's been remarkable from all the issues in the beginning, getting him to swallow and remember, and yeah, he's really done quite well. His CD4 count has come up. I think it's close to 100 now. I don't remember exactly, but and his mouth has cleared up. He had a rash. It looks much better.
Even that,
And he's gained a fair amount of weight too. Yeah,
Yes.
he's jumped up.
we're all the way up past 50 now.
Yeah, he's
Yeah.
he's done quite well. And a lot of that is a credit to you and you sticking with it. So you talked about how this was a big fear of yours, and he's doing wonderful, you're doing great. Going back in time, can you tell us a little bit about kind of when you were diagnosed with HIV?
I was pregnant with my daughter and I didn't know. I got a kidney infection and it was hurting really bad. And so I went to the emergency room and I found out that it was a kidney infection. I'm like, okay, I'm just here for a kidney infection. That's fine. And I had a doctor, he come in, or he could have been a nurse, or I thought he was a doctor. And he asked me, he says, do you know anyone that has HIV or do you know of you have? And I'm like, no, what are you talking about? No, mm-mm. So they leave, come back, they ask me again. I'm like, no, I just told this other man no. Like, what are you talking about? So then another doctor comes in and he kind of was more calmer, and he had explained to me that they ran the test and they had found out that I was HIV positive. And like I said, with Cody, it was 10 times worse because I didn't know how to handle it. I just was bizarre in the hospital when I tell you.
And how you were pregnant with
Catherine.
your son's younger sister.
Oh, yes, sorry.
And how old was your son when you
He
were
was
diagnosed during your next pregnancy?
About a year and a half.
About a year and a half.
And I was maybe 5 months pregnant when I was in the hospital and found out.
And did they start you on medicines right away?
Yeah, they told me, and of course they sent me to the doctor and they told me that they would run the test and give me medicine. And so I went back to the doctors. Of course, like, there was just so much going on in my mind. I didn't even know what was going on. I just thought that this was the end of the world, because that's the spectrum. And honest, living in our neighborhood, it's just, if you don't know about it, then you don't know. And now I know that I don't have to act like harsh or like it's the end of the world, because it is a bad thing. But at first I didn't know these things. And so now it's like I'm calmer about it. But some people are not calm about it. Some people will treat you like that is the end of the world. Your death right there, like, be gone. You got to stay 50 feet, million away. Like, it's like, so it was really hard at first. But then, like I said, I tried to keep the mentality that I had to get better because of the kids. And it can be hard for an adult alone. But when I found out about Cody, now it really makes me want to worry about myself also, because it's hard for yourself, but when your child is sick, it's even harder, because now I have to worry about if I'm gone or how he will feel when he is older, because this is not something he signed up for. And well, none of us signed up for it, but he didn't get to make the bad decisions or however it happened for it to happen. Like, he didn't get the choice to be careful.
Yeah.
Like,
we talked a lot about kind of it being no one's fault,
Right.
either in your case or his case. You did really well when you were diagnosed taking your meds, right? And your daughter is negative,
yes,
right?
yes,
Which is
thankfully.
wonderful.
Yes.
And you took your medicines, but from what you're saying, it sounds like this is renewed a little bit more focus on you to help take your own meds and
Yes,
be in care.
Yes, because when I had Kat, when I had my daughter,
We talked about not using names, but nobody else talked how hard it is not to use your kids' names.
when I had her, I kind of fell off. And even now, I sometimes can be sketchy. I worry more about everyone else than myself. But it is
Common with a lot of parents.
yes, and it is a lot easier with y'all's help, because without, if I would have never found about Cody and I wouldn't have came here, then I wouldn't have stayed on track. Like I said, I wasn't taking my own medicine before I found out about Cody. And I tried, it was like an on and off thing. I just couldn't stay on track. And when I found out about Cody, with y'all's help, and now it just clicks. It's like, well, we gotta take Cody, we gotta take care of your medicine. Like, it's like a routine now.
Yeah.
Like now it's just stuck in my head.
And that's the goal, is to just make
Right.
it part of your life and
So it's a lot better now.
Yeah.
It's like, at first it was really hard, but now I try to focus on taking medicine, and I figure if it gets to where he needs to talk about something, then we have people we'll be able to talk to.
Yeah.
And figure we'll take it a day at a time.
yeah. You guys are, I said it before, I'll say it again, you guys are doing really, really well and both being very strong. Again, going a little bit back in time, when you delivered your son, your firstborn, by cesarean section, you had an infection at the time, so they did the cesarean section. No one knew about your diagnosis at that point, and then you said you breastfed for a few months.
Yeah, about like 3.
3 months, and then about a year and a half later was when you were diagnosed.
Yeah.
After you were diagnosed and you were getting your care by your doctors and you were taking your daughter, she was getting the medicine after birth for a period. Did anyone talk to you about timing of your infection and the need to maybe go back and test your son?
No, and that's why I never thought about it. Honestly, because all my papers always said negative, I just thought that it was like it was not possible. I thought he's safe. I'm like, he's good. He was before I found out, so he's gotta be good. Like everything said negative then, so I'm just like, oh, that's gotta be that way. He's gotta be good. So I never thought I should get him tested. So then when we found out and I was asked, well, why didn't you think to get them tested? It made me feel like a bad parent. I will keep it honored. It really did, but it didn't cross my mind. I thought that they were fine. I knew Kat was a worry because I was pregnant with her. But with Cody, I didn't think there was even a chance.
Yeah. Yeah, we talked a little bit about how,
Oh,
there's a
okay.
timing of,
Yeah.
no, I mean, we talked about the timing of when we test women during pregnancy, and it's hard to capture with kind of the current recommendations. A lot of times we don't repeat testing. And it's hard to go back and know exactly, but you're with your partner, both their parents, and he was ultimately diagnosed as well, right?
Yeah.
And you were with them you were with him throughout that time.
Yeah. I was with him for,
Yeah.
pretty much.
And part of the reason we're having this conversation with kind of over 100 people in Maryland and around listening is it shouldn't be your job to point that out. It shouldn't be your responsibility to know about the nuances of testing. And so part of the goal with this conversation is let's help all of us have a nuanced conversation and kind of ideas about how to, in the future, maybe do things differently so that your situation isn't repeated. And I really appreciate you sharing your story, because I do think it's going to help a lot of us do our practice and help a lot of moms and kids out there. Anything else that you wanted to mention while you have the opportunity? Then I'll turn it over to Dr. Agu, and if she has any things that we didn't touch on that you wanted to ask.
No, not really. Help is the key. I guess I will say that, because without the assistance or without having people actually feel like, without feeling like you care, then we would not be here. Because I made it known when I first started coming to the doctors, I felt like I could not trust anyone. Like, it was like, I can't tell these people anything. But now I don't feel like that. Now I feel like if I'm worried, then I can talk to these people. Like, it's like a comfort zone. You have to make people feel like they want to be there, or else we're not going to. I deal with people every day that don't even go to the doctors. So it's like they're afraid of the doctors. So they could have it and not even know, because they don't go to the doctors. Like,
Well, I appreciate you feel comfortable here. It's something that we work towards and we can always improve upon. So I'm glad to get that feedback that this has been a safe space for you.
I just wanted to highlight a couple of things. One, I wanted to thank you so much for sharing your story. There's a lot of kudos for you in the chat for your strength and your honesty and your vulnerability to be here and to share your experience to help us learn from it. And that, you know, this is a crucial conversation, meaning that we want to hear what we can do better. And we want to hear from you, expert mom, what you would recommend if you had to go back in time to improve things. So when we have the panel discussion, your voice is absolutely elevated to an expert because you have lived it and you can help us learn to improve it. Okay, so I want to acknowledge you in that space. Want to acknowledge, so sitting next to you is Jamie Margolis, who is a mental health case manager who's been by your side and I know has been a big part of helping you and your son adjust. So just, you know, thank you for trusting her and us and for again sharing your voice. So with that, I want to open up to some discussions and then please drop your questions in. You know, I wondering if from each of you and Anna and Jean and everybody who has spoken or not, what do you think are the critical lessons that we've learned from these recent transmissions that we've discussed and what you've heard about the others so far? What do you think are critical lessons?
So I'm happy to jump right in and talk about this because I find, you know, her story is so tragic and so unnecessary, and it was a real failure of the healthcare system. Absolutely, women should be tested at entry into prenatal care and at the time of the beginning of the third trimester. But I like to take that a step back. The CDC recommends that everybody be tested at least once in their lifetime between 13 and 65, and certainly more frequently when there's any risk. And, you know, that's a number of things, including, you know, any STDs, living in a populated an area where there's a lot of HIV, like Maryland, should trigger a provider, a gynecologist, a primary care provider to at least discuss that option with people when they come in for their care. And my feeling is that first of all, if a woman is on antiretroviral therapy, undetectable when she gets pregnant and remains so, her risk to that baby is zero. It's zero. So that means we really need to identify people with HIV before they get pregnant, for persons that get pregnant. So I really think that, and how we get that message out to the general population, I think, is the key to not only people, but providers. Like when you have folks come into your primary care practice or your gynecologist, and you're talking about risks or, you know, STDs and sexual health, talk about HIV and offer that testing, because that's how we're really going to end this epidemic.
Anna?
Yeah, I was just going to say the other, you know, from an obstetrician's standpoint, you know, the recommendations, especially in a high prevalence area for HIV, are to repeat third trimester testing. But, you know, a lot can change in 3 months between 28-week labs and an admission to labor and delivery. So I guess my takeaway message is always have a very low threshold to retest. And, you know, it's really important to screen patients for risk factors and ask about any, you know, any potential changes since you last tested them. Because, you know, you can have a initially negative HIV test in pregnancy, and then it's not uncommon, unfortunately not terribly uncommon to hear of new HIV diagnoses in pregnancy. So that's particularly what we want to avoid for perinatal transmission.
Particularly with such a high rate of transmission if it's acquired during that time. And I think some of it has to do with how we even think about pregnant women and whatnot. We even think they're sexually active beings, right? So I think
Don't forget.
Fair. Plus, I think also in partnerships, people may be less likely to use the things that may have prevented transmission because now they're pregnant and they're not worried about that, right? So I think important to.
Yes. And also asking about partner status. I know we, as obstetricians, we probably don't do as good of a job about asking about partner status for things like herpes or other infections, but definitely for HIV is something we would want to know about, and to hopefully direct that partner to appropriate care as well. And for the OB or obstetric patient to potentially offer them PrEP or pre-exposure prophylaxis.
I think an important thing to mention here is that these spike in cases, and we can talk about if we think it's a blip, a spike, a beginning of a trend, and what underlies that. But there's also record numbers of congenital syphilis, there's STIs, everything has gone up. And, you know, I
Mhm.
think it's not just talking about HIV, but it's a package of all the things, right? And where we
Right.
can prevent or treat, because those factors have risk factors as well. Now, saying that, what do you think is underlying this? Do you think this is a blip? Or do you all think this is a tip of an iceberg, canary in the coal mine? What do you think is happening? Would love to hear from all of you, because this is, you know, again, record territory for me, but what do you all think is happening here?
One of the things that I thought was really interesting was that many of these cases seem disconnected. There's not a singular thread that, you know, I think
Mhm.
working in this area, we're kind of all holding our breath to see if COVID has an effect. Like if there's the disconnection from care that leads to a bunch of new diagnoses from COVID. And I think that we're still gonna be waiting for that for a couple more years. We know in Baltimore that there's a delay from acquisition to diagnosis. And I think it's going to be, we're still going to have a lot of time before we can really tell what the effects of everything around COVID will have on HIV, whether that's from perinatal transmissions or just you know, new diagnoses in general, which will then trickle down to perinatal transmissions. We may be a decade away from seeing what the effects of COVID are on perinatal transmissions. I think that what is interesting to me is that none of these have that singular thread. There's so many different variables that are at play, but perhaps there are aspects that can be tied to COVID, like, you know, disconnection because you aren't getting into prenatal prenatal care. Maybe there's less availability because your care was they changed their schedules, and that was a long-term effect of COVID. Or maybe there's a holdover of insurance regulations by that care provider because of COVID. I think that we need to backtrack a lot to see if there is some effects that were related to COVID. And you know, but the other thing that sticks out to me is that health literacy is a huge aspect, both in the provider level and at the patient level, and in many of these. And I think, you know, I think aside from our expert mother, I think that health literacy was a factor in the other two cases. And I think on the patient level of understanding the diagnosis themselves and how medications can assist.
Speaking to our fab mom, I wonder, since you're the most recently pregnant one in the group, I think, well, maybe Anna is, what do you think of the messages that pregnant women get about sex, as you know, prevention of sexually transmitted infections or HIV? What messages do you think that we're giving our pregnant moms?
I'm sorry, Allison, was that a question for us?
That's a question for you all, yes.
Sorry, we were our own conversation had kind of taken a turn on our end. So do you mind repeating it?
Yeah, so sure. I was asking her, what does she feel like are the messages that pregnant women or she received as a pregnant, you know, person about sex or prevention or her risk for sexually transmitted or HIV or partner testing? What are the messages that she remembers receiving?
Honestly, none.
Mm.
When I was pregnant with my son, I went to my doctor's appointments, but when nothing, I guess, popped out on the charts, like, oh, this is a problem, they didn't say, do you think you should get tested like regularly? Like, it was never like an option, or like do you know about this? It was just, oh, your test came back regular, you're fine. Here's your next checkup date, come back. You know, like even prior to me being pregnant, the doctors never really, like, it was never like about the sex life. I feel like now when you go to the doctors, it's just a checkup. You're okay, you're living, that's that. Like when it comes to the big discussion about sex, it's like it's so awkward. Like, and now it's like nobody really knows about the repercussions of if you're not careful. Like, yeah, everybody knows their letters and what they are, but they don't really know what it is. They're just listing off diseases. They're just like, I could catch that, but they don't really know what that is. Like, because they're not being taught, like even down to like how it's not in schools now. Like nobody's really teaching anybody what you can get. Like, so without the knowledge, everybody's just gonna get it because everybody's just out here doing stuff now. That is the youngins stuff to do now, is the stuff. Sorry. If
No,
that
you-
makes sense.
That made a lot of sense. Thank you.
I guess all everybody wants to do now is to do and pop out babies and They don't even know about the, what if you're not careful? Or if it was an accident and something did happen, you can do this to.
Yeah.
That's a
to
good
prevent
point
that.
too. Yeah,
Like,
that's a really good point.
sometimes people just feel like,
So-
well, I'm already here, this is happening, that's the end, like. It's the end of the world, like nothing's gonna make it better. But you don't have to feel like that. But some people do.
Yeah. So it's interesting because it sounds like you're hitting it from many angles and preempting one of my questions. It was awareness and education from the individuals who can be pregnant and what's happening with them. But also I hear you highlighting the medical system and what people are even aware of or counseling you about. So it's sort of, you get the message that you're all good without the sexual history or the exploration of how you may no longer be good, right? If, what's
Right.
happening with your partner, or what, are you having sex, who, what, where, when, how, that there needs to be some bolstering of that to make sure people are preparing you so that you can stay negative, right? Am I getting that message right?
Yes, more or less, like, because if you're taught about what you can do to prevent it, then it might not happen compared to if you just are ignorant to the fact and you don't know.
Yeah.
Then it's like, you're just gonna do something and it's like, I wanna do that. There's nothing bad gonna happen, but something actually bad could happen, but you just don't know.
I'm looking in the
Because you're not-
chat. Oh, sorry about that. Sorry I was saying, looking in the chat and seeing someone saying that, there was no one thought to test the middle class white woman from the DC suburbs. And, so she was diagnosed later on, but it was not thought to test her. And so I maybe can turn to my OB colleagues and say, I know the recommendations are first and third. What's your sense of, not just at Hopkins, but what's your sense beyond in terms of how tightly those regulations or recommendations are followed? And are we potentially missing people in those not following those? Curious what your thoughts are.
So, yeah, that's a big question. So I think we probably do, and Anna, you could talk to the sort of private patient world, but I think in academia, we do a fairly good job of having those discussions that are difficult that our mom pointed out. And that's getting a good sexual history. And that means, really having to ask some personal questions. And as providers, we need to get comfortable with that. And I think that comfort, that has to also, most women do go to see a gynecologist, so that's a great place to start. But it also needs to be something that I think that primary care providers are also comfortable with, so that those discussions become comfortable both for the provider and the patient. So when the patient comes in, they might be more likely to say, you know what, I really messed up. I did this, or I have a new partner, or I think my boyfriend's fooling around, or I'm, can you just test me anyway, just to be sure? Because that's what I usually get. It's like, yeah, I'm in a stable relationship, but you know what? Go ahead and do a test anyway. Just, whether it's an STD testing. Most of my patients are HIV, so I don't have to do that. But sort of making it a comfort zone for people, not for you to ask the questions, but also for people to come to you and talk about those things. Anna?
Yeah, one thing I'm hearing from what you're saying, Jean, is, making sure that we as providers are creating a safe space for our patients to be able to bring those concerns to us in the first place, which is hard when we're, pressed for time and clinic is overbooked and things like that. But just being mindful that, our visit could be the one missed opportunity that makes the difference between diagnosing and not diagnosing somebody. I'm not in private practice, so I can't speak too much to like what it looks like outside of a big academic center. But it's easy to imagine that if you live in a lower prevalence area, or if you don't, see a lot of HIV in your practice, it's probably going to be a lot lower on your differential. But if you look at the CDC risk factors that are listed, there's really not, the threshold is not high to offer HIV testing to somebody. Certainly like multiple partner, any STI diagnosis. So that covers a lot of the population. And of course, we know that risk-based screening still misses a lot of people. So I think, from the provider standpoint, I would just say have a very low index of suspicion for it and get comfortable asking patients if they've had HIV testing or if they would like HIV testing. And then just, looking at reviewing the guidelines and knowing how to follow up when they have a positive test.
Oh, wow, it's 12:52 already. Okay, so one of the things that I wanted to ask, I mean, my sense is that there is also a bit of the game is over, right? There's some complacency about HIV and where the who gets the messages that they are at risk. You know, certainly if you watch TV and the ads for HIV treatment, you don't see a lot of women, or you definitely don't see any pregnant women. So you know, I think Fab Mom alluded to not getting any of those messages, and I think that's an important thing to think about. How are we messaging that you may have risk? Recognizing that there were so many, I think as Matt said, there were so many different things at play, falling out of care, you know, lack of health literacy. There were so many pieces. It sounds like it's a multi-pronged approach to address what's happened. So if you had to pick your game changer, right? I'm going to ask each of you, your game changer, what would be the thing you would double down on? I know that people from the Maryland Department of Health, and what would you double down on and put your dollars down? And each of you say something different so we can get all the things, but what would be the thing you double down on in helping interrupt what is potentially happening here? Let's start with you, Matt. You're at the top of it.
I think we need better health education for providers across the board. Not, you know, there's only a few, I would say a few of us who are comfortable talking about all these aspects. In the comments, there's so many aspects of people talking about that there's lack of talk about sexual health at primary care visits or at general health visits. Around PrEP, there's so many comments about just PrEP in pregnancy, PrEP for women of childbearing age. I think general health literacy and education for more folks around HIV prevention, surveillance, and testing to make that more prevalent, not just for people at University of Maryland or at Hopkins or at major medical institutions, but in private practice or wherever you go. So it's standardized across the state. It's not on the patient to ask for those things. It's on us as providers to make sure that they're readily available.
Yeah. Jean?
Gee, Matt, you just covered a lot. So I'm sure I can add much to that. So my biggest pet peeve a few years ago when PrEP was being rolled out was that there were never any women. And I would go to the CDC website and there would always be pictures of men. That's gotten a little bit better. But now I see PrEP commercials and it's men again. And, you know, yes, I understand we have to focus on those rates that are, you know, those groups that have the highest rates, but we often leave out women. They always become the second, like the second tier of thought, you know, or people that we address this to. And I would just really like to see us more often including them in the conversation and making sure that, you know, women are at risk, you know, and that more so than, and particularly cisgender women, you know, so, you know, and heterosexual women, because they're not perceiving themselves to be at risk. So that we need to, and then they're more at risk than men are, who are heterosexual. So just throwing that out there. Did that make sense? I thought I was going all
No,
over
it
the place
definitely
there.
did. Definitely did. And I think important
Thanks.
to add that while we're saying women, not everybody who can bear a child is a woman. And so imagine
Yes,
you're
thank you.
talking about women, so not cisgender
Yes.
women not represented. What about the trans man
Yes.
who can still, right? So I think we're really talking about non-screening. Anna, what is
Yes.
your double down game changer to interrupt what's happening?
I mean, I think one important opportunity that has a lot of room for improvement is, offering PrEP in the OBGYN setting, and having our providers, even general obstetrician gynecologists, basically at any opportunity to just, use PrEP as part of our toolkit. And of course, early and often repeat HIV testing, a lot of miscare opportunities for that probably. But yeah.
And an attendee is highlighting wouldn't LND, just universal LND testing versus risk-based testing, would that be, something that can be done, basically amplifying the opportunities to capture people, importantly. And just, if I can use my moderator privilege to say, well, talking about PrEP, I think critically important, just as important, I think, as we know many of the individuals had challenges maintaining adherence, is thinking about, as we move to long acting and other more sustainable biomedical strategies that may help people suppress their viral load, not leaving pregnant individuals out of that conversation. I know the impact of the International Maternal Pediatric AIDS Clinical Trials Group is planning a study of long acting injectables for pregnant individuals. And that's, I think we cannot leave that out. So many, it's hard, you're vomiting, you're about things are happening. Can we have alternative ways to help people maintain suppression? David and Fab Mom, you get the last words on sort of doubling down. What do you think would be the thing that you needed game change around this?
You think is one, what do you think is one change we could make to
Yes.
kind of help? You talked a little bit about education as kind of helping people know what's out there.
That's really it. I feel like lack of education is the problem. Because without anybody knowing, how can you correct it? Now, I'm sure that's gotta be complicated for y'all because I don't know how y'all could really get the education concept out to yes, you can educate your patients, but for the people that are not your patients, how is the education going to get to them? Because they're the ones that are really the problem, because they're the ones that aren't coming to the doctor to find out if they are affected.
I think that's absolutely right. I think my game changer would be just making it easier to access healthcare. And maybe getting to the doctor is not easy. Getting a
Right.
prescription is not
Right.
easy for people. So how do we get healthcare to the people that need it, both
Right.
education and the actual medicines testing
Right.
that they need?
So, I mean, we're talking about people who walk through the door. What I hear you both saying, what about the masses that have not walked through our doors, and how do we reach them in terms of educating them about their risk and testing? And that includes the masses that are not the providers that have HIV expertise, that are seeing the bulk of patients.
Right, because if you don't know that, if you don't have HIV, but then your doctor is a regular doctor and they're not telling you about the possibility of HIV, then how will you know how to not get HIV? Because you're not being taught about it.
Yeah.
And then, like I said, with us not having it in school now, it's nobody's really teaching their kids anything.
Yeah.
Like, so when we get old enough and we're actually doing it, then we're just doing it. We're not thinking about the repercussion. Like,
Yeah.
And unfortunately, I just see a lot of people. I got a big family myself, and I made mistakes, and I see them making the same mistakes because, like I said, it's lack of education. So it's like, however that could get worked in there, maybe it would help. Because if I would have known, then maybe I wouldn't have been in this place. But because I didn't think about what could happen, because I wasn't taught it, once it happened, I just was like, oh my goodness, this is happening now. Where did I go wrong? But if I had known what I could have done for that not to happen, then maybe I would have just felt like it was like I did that because I had the information. Like, you can't really feel like I didn't know where I went wrong if you know where you went wrong. If that makes sense.
Totally. Thank you so much.
It makes all the sense in the world. And I'm looking and realizing now time is out. And so you actually get the last word. I think what I've heard, and this is by no means the end of a conversation. The idea from this, and I have the model for crucial conversations model. We do all this, we look, we assess, we reflect, we come together, and then there are some next steps beyond that. There are many comments in the chat about how to approach and what to do. And this is what we need to be thinking about and talking about, and elevating the voices of the individuals who are at the front lines, literally, like our fabulous mom who experienced it, to tell us what we need. So, when I think about practice improvement, I think about considering the connections, asking the questions, thinking about timelines, thinking about testing, and not talking ourselves out of it. We're having perinatal HIV cases. And I don't think, Marilyn, that we're just it. I think we are going to be seeing it. And I don't think we're at elimination. Suspecting, treating, testing, preventing, and continuing to dialogue and sharing. With that, I'm going to stop and thank you all for your time, attention, highlight, your contribution to the conversation, our patients, including you, Fab Mom. And I want to thank Jamie for being in the room to support you, and David for the amazing care and clearly the connection that you have developed with mom and son. The teams here, the JH Wiki team, want to thank the Perinatal Task Force for jumping on with us and giving us their thoughts and feedback and for all the work that they're doing. And I've said to them, it's not a failure by anybody. It's how do we all get together and make sure that we stem the tide. And then want to leave you with some resources. Perinatal HIV consultation, referral services 24/7, our Hopkins resources, our Maryland resources, where you can reach out both locally and nationally if you have questions or and need some guidance, as well as have patients be seen. With that, we're going to stop. Thank everybody for their time and attention, and see you at our next toolkit next month, which is on trauma. Thanks, everybody.